Menon. I'm a orthopedic spine surgeon. Though my core competency is on spine surgery, largely to attend to your needs, I will be talking a little bit, rather my emphasis in today's talk will be on the epidemiology of spinal tuberculosis. I will spend some time on that. Of course, I will discuss clinical aspects, imaging and surgery, etc., etc. But the emphasis is going to be epidemiology, and you'll see the reason why. I don't have any disclosures. So today's lecture plan, I will emphasize, as I said, on the epidemiology and how the epidemiology of tuberculosis is changing globally, particularly in India. I will touch upon the diagnosis with newer tests, indications for surgery, and some of the personal experiences with our own evolution before I close with the messages. Now, the interesting thing about tuberculosis, if you look at the world map on tuberculosis, you'll see that, which one is the pointer? You'll see that this is the southern hemisphere is where all the tuberculosis is from. You have the Russia, the Chinas, the India, the Indonesia, the Philippines, and a whole lot of Africa and Brazil. This is where tuberculosis is concentrated all over the world. Yet, interestingly, all the publications, a vast majority of the publications on tuberculosis have come from this area: North America, Canada, Europe. Of course, there are some from India, China, etc., etc., and the Middle East. But the literature on tuberculosis, interestingly, has come from the other parts of the world. And obviously, there needs to be a paradigm shift, and it has been happening in the last 10, 15 years. We have increasing number of publications coming in from the less developed countries, because, as you will see in a minute, where tuberculosis is endemic, the clinical features are different, the epidemiology of the disease is different, everything is different. Whereas in the non-endemic countries, it's a different pattern. So the WHO every year publishes their update on tuberculosis. This is from 2017. There is actually another update in 2019, and from 11 million, it has increased up to 13 million. And from a 20%, which was in India, now in 2019, 25% is in India. So that's 1/4 of the global representation on tuberculosis is from our country. And there are supposed to be 150,000 cases annually. This again is in 2017 data. The interesting thing, between 2019 and 2020, one thing has happened is, in the WHO report in December 2020, is that the total number of tuberculosis globally and in India has decreased. We don't really know the reason. Perhaps because of the COVID pandemic, we believe it is under-reporting. People have not been able to report, people have not been able to go to the hospital, they have not detected the tuberculosis, they have not treated the tuberculosis. So it's probably just continuing. So the 2020 December report, which shows a decline in global tuberculosis, is perhaps not a true information. We're not quite sure about that yet. Now, this shows you what happens in the first world countries, in the developed countries. So in the US, for example, 3.7% of all tuberculosis are spinal tuberculosis. Less than 4% is spinal tuberculosis. The prevalence has actually decreased in the US from 0.7 to 0.5%. And this is an adult disease. It happens in elderly people, 50 plus people, predominantly with comorbidities. For example, they are diabetic, drug habituators, alcoholics, HIV positive people. Now, this is the Western world statistics. This is completely different from the statistics in India. In UK also is the same thing. People in the older age group, 50 years and above, have tuberculosis. People who have multiple comorbidities, HIV, diabetes, etc., they have tuberculosis. The younger people, children, hardly ever get affected in their countries. The additional feature in the UK is that vast majority of them are expatriates. They are not natives of UK. They are probably Asians, Indians, Pakistanis, Filipinos, Afghans, etc. So these are the people who get tuberculosis, particularly tuberculosis of the spine, in the non-endemic countries or the developed countries. In stark contrast, let's look at some of the other data coming in from South Africa. What is remarkable about South Africa from the rest of the world? South Africa is the HIV capital of the world, perhaps you know that. 76% of all tuberculosis are HIV positive. Can you imagine that? If you look at India's data, we are 3.4% of all tuberculosis. This includes pulmonary, spinal, extrapulmonary, peritoneal, lymph node, all kinds of tuberculosis. All put together, we have a 3.4% tuberculosis co-infection with HIV. Whereas imagine in South Africa, 76% of them are HIV positive. It's a huge disparity. So if somebody is working or seeing a patient from South Africa, if he has tuberculosis, it's almost certain that he is HIV positive also, because the statistics itself is so clear about that. Now, the other interesting thing about tuberculosis, one of my colleagues, Bob Dunn, wrote this paper from Johannesburg, and if you look at the data, it says spinal tuberculosis, little less than 20% affect children. Whereas in India, we have 33% of spinal tuberculosis affect children. 1/3 of the tuberculosis of the spine are children. So adult disease is separate, children disease is separate. And there's a reason why pediatric disease has to be treated separately. That is also different in some other countries like South Africa. This epidemiology is the key to our understanding of tuberculosis. So I worked for 7 years in Oman, and this is one of the series that we did in 2014. We published this report on spondylodiscitis, and you will find that out of 38, only 4 patients had tuberculosis. All the others were pyogenic. So pyogenic infections were far more commoner in the Omani natives than tuberculosis. And the 4 patients who did have tuberculosis were all Asians. They were not Arabs. Omanis do have another problem. The Middle East all has brucellosis, which we don't have so much because we don't eat or drink camel meat or milk. So we don't have brucellosis. We do have, but it's less commoner in our population. If you make a diagnosis of brucellosis without adequate evidence, you're likely to be wrong. It's more likely to be tuberculosis in our country than brucellosis. But pyogenic was the commoner infection in the spine. So if you look at anywhere in the Middle East and make a diagnosis of tuberculosis, the chances are you're wrong. It's much more common to be pyogenic infection in the spine. Again, for this period, 1998 to 2006, we were serially, I belong to Kerala and I was working there before I came here. So we were serially studying our tuberculosis and pyogenic spondylodiscitis patients for almost 15-20 years. So this is the statistics for the period of 98 to 2006. And you will find the number of tuberculosis patients are remaining more or less constant. 40 to 45 patients per year we are operating in tuberculosis. But look at the pyogenic dyskitis, they are progressively increasing. By the time we reached 2006, we had approximately 35 cases per year of pyogenic spondylodiscitis per year. Why was this happening? Was there something different happening? So there are several reasons. One is we have an older population. Our population is aging. We have a lot of elderly people, psychiatric people, diabetics. Transplant. There are a lot of people on kidney transplant, liver transplant. A lot of people with malignancy, a lot of people with rheumatological disorders who are on immunosuppressant therapies. And all this, people on dialysis, all this increases the susceptibility not only to tuberculosis, more importantly to pyogenic dyskitis. So that's one of the things was the age of the population, and the other was the immune susceptibility of the population. And because of that, we found that the pyogenics were increasing. The other thing was in 93, our state government mandated that you cannot treat tuberculosis without RNTCP guidelines, and therefore we had to have histological diagnosis from 93 onwards, and that made a huge difference because our detection rate of pyogenic infections started increasing. This is mandatory. Every time you see a destructive lesion on the spine on the X-ray, we start anti-tubercular treatment. This is incorrect because we realized that by the time we reached in 2005 and 2006, almost 50% of the cases were actually pyogenic dyskitis, and we were banging them with anti-tuberculosis drugs for 10 months, 12 months, etc., which was not indicated. So this is the other epidemiological instance. Now, we have this 2 very famous authors. Some of you might have heard of them. Tuli is from Banaras Hindu University, Varanasi. He published his first report of 10,000 cases in the early 80s. And the other was Shanmugh Sundaram from Chennai, who was part of the MRC trials of UK when in the early 80s. The first published global trials were the MRC trials from UK, and that was in the 80s. And they also published huge volumes of pulmonary tuberculosis, extrapulmonary tuberculosis, and they have given us some guidelines based on their statistics 40 years ago. That statistics is no longer valid. This is what I want to bring out. So they told us that tuberculosis affects socioeconomically challenged people. That is true. That's still true in a large part of India, but not true in many other parts. 1/3 of the population who get affected by pulmonary or extrapulmonary tuberculosis are children. True in some parts, not true in other parts, which I'm going to show you in a minute. Most of these people are immunologically or nutritionally challenged people. True in some parts, not true in some parts. And what is the differentiation? This is what I want to tell you. This is the changing epidemiology that we've seen in the last 10 years. So the last 6 months, just to give you the statistics from this very city, we operated 12 cases in the last 6 months, 3 were children. That's good. So 1/3 of our spinal tuberculosis population is children. Okay, that sounds good. They are all from the poor socioeconomic background. They are nutritionally challenged. They all have systemic manifestation, typically described in your textbooks. They are cachexia, malnourished, anorexia, poor appetite, night fever, sweats, everything is there, chills and rigor, it's all there. The only difference that has happened is that we were told that thoracolumbar lesions are predominating, and the rest of the spine is not so commonly affected, but the distribution is more or less equal. There's only one case who had thoracolumbar tuberculosis. All the others were in the other parts of it. But anyway, the epidemiological data is by and large true in this population. Why that happens? Because tuberculosis is endemic in this region. In some of the non-endemic or lesser endemic regions, this is not true. Look at the 98 statistics which we compiled from Kerala. We had 88 children, 88 patients in that 1 year. None of them were socioeconomically deprived people. They were middle class people, ordinary Aam Aadmi like us walking around. The only clinical feature they had was pain or deformity. None of them had systemic manifestations of tuberculosis. No anorexia, no nausea, no night sweats, no chills and rigor, no wasting. They were ordinary folks like us. They just had back pain. They were investigated for back pain, and that's when we discovered that they had tuberculosis. None were HIV positive, there were no diabetics, there were no alcoholics, there were no children. So for the last 20 years, tuberculosis of the spine in children in Kerala is on the decline. In the last 10 years, the reporting rate is 0 in Kerala. So this is amazing. And yet Kerala is endemic for pulmonary tuberculosis. So why has this paradigm shift in epidemiology happened? It has happened. I'll tell you the reasons in a minute. This is a newspaper in Malayalam from Kerala which says that it's setting an example and winning. How is it winning? Because we have, this is 2018, 67 cases per 100,000 against a national average of 138 per 100,000. There is a 3% decrease per annum in pulmonary tuberculosis in Kerala. Every year for the last 15 years, 3% has been decreasing every year on year for the last 15 years. How has this been achieved and why has this been? For the last 10 years, as I told you, there is not a single child in Kerala with spinal tuberculosis. Pulmonary tuberculosis is still there, extrapulmonary lymph node is there. Why not spinal tuberculosis? It's interesting to contemplate. One of the reasons is you cannot start ATT unless you follow the RNTCP guidelines. Unless you have histologically proven diagnosis, you cannot start, or immunologically, serologically proven diagnosis, you cannot start anti-tuberculosis treatment in Kerala since 93. So, you know all the clinical features. I mean, you don't have to be taught the clinical features of tuberculosis. Anorexia, loss of weight, malnutrition, malaise, fever, night sweats. Now this classically occurs in the endemic form where the lower socioeconomic strata is affected. If you have the middle or upper socioeconomic strata affected in a non-endemic country, for example US, UK and some parts of India, you would not find this happening. Their complaint is only one: back pain, swelling, sometimes swelling, occasionally deformity. So this is the difference between an endemic population being affected and a non-endemic or slightly differently endemic population being affected. So this is why we need to relook at the original data published by Tuli and co-workers. Why is pediatric tuberculosis so much different from adult tuberculosis? It has to be treated as a separate entity, because even though you give the complete treatment, anti-tubercular treatment for 6 months, 9 months, 12 months, whatever is the duration of treatment prescribed, you complete the treatment, yet it's a growing spine and deformity can progress. This is a classic example of a child who had tuberculosis of the spine, who was treated appropriately medically at that time, and the disease healed, the child became asymptomatic, but as the child grows, you can see the deformity progressing till it becomes a very large, very severe knuckle deformity, even after the disease has healed. And now at this age, this is about 15, 16 years old, now the child has come back. What started at 4 years of age has come back at 16 years of age, now with severe deformity and progressive neurological damage in the lower limb because the spine is stretched over the internal gibbous. So this is what is special about children. Not only do you get deformity progression during the active phase of the disease, but even after the disease has been completely eliminated or cured from the body, the deformity can progress because the child is growing, and as the spine grows, you get this type of deformity. We have a surgeon called Dr. Rajsekaran from Coimbatore who's published this report on called Spine at Risk Signs. He has described 4 radiological signs where you can predict which are the children who will progress into such grotesque kyphosis as they grow. And he has described these 4 signs, and the signs are opening up of the facet joints, multi-level disease with opening up of the facet joints, retropulsion, progressive retropulsion or posterior translation of the diseased vertebral fragments into the spinal canal. In the coronal plane, which is the AP view, if you have lateral translation of the vertebrae, that's another indication that that segment is unstable, it can progress. Or if you have complete hemivertebra like pattern. So these are the 4 spine at risk signs which help you predict even at this stage, at the very early stage when the child is being treated, you can predict this child needs surgery, otherwise this deformity is going to progress even after the treatment is complete. And this is where we choose to operate. There's no, I mean, you can operate here, but then the results are not as remarkable as you would have achieved if you had done the treatment there. So again, between 2001 and 2005, we published another report from Kerala again. This time we had 162 spine cases. There were very few systemic manifestations. No fever, no chills and rigor, no night sweats, no loss of weight, no anorexia, nothing of the sort. The complaints, they were all adults, 100% adults. There were no pediatric cases. All of them had pain, swelling and deformity. There was 1 case with fever. There were 3 cases of psoas abscess. From the traditional literature, we are told that more than 60% of them will have local abscess. Spinal tuberculosis will have local abscess. 30% of them will have huge psoas abscesses. We only had 3 of psoas abscess. Somehow this reflects the immune status of the patient. It probably reflects the nutritional status of the patient. It reflects the endemicity of the disease within that region itself, and multiple other factors, probably social, cultural, educational factors as well. Now there are 2 other important things. One is the distribution of tuberculosis along the spine. Traditionally, we are all taught that it is thoracolumbar junction where you get maximum lesions, but now that seems to be changing. It seems to be getting equally distributed all along the entire spine. The other important thing is that multicentric disease seems to be increasing. We know the reason, precise reason for this also. Earlier we were taught in traditional literature that tuberculosis affects 1 vertebra and it affects 1 vertebra. In vast majority of the cases, you rarely get what is called multicentric simultaneous lesion. But we know the cause of that. The cause of that is MRI scan. Previously all diagnosis was made based on X-ray, and if you look at X-ray, you will miss several of the, you will pick up only this lesion where the vertebra has completely collapsed and destroyed with abscess formation, whereas a disease which is starting early, very early stage of the disease, you may not pick up. These will not be picked up. Only the large with the soft tissue shadow, the bird's nest appearance and the epidural abscess, only those will get picked up. The reason for picking up multicentric tuberculosis is largely because of MRI scan and PET scan. If you do a PET scan on this, you will find extrapulmonary tuberculosis also. You will probably find lung lesions, you will find peritoneal lesions, you will find lymph nodes and various other things. So the investigative modalities have also evolved over time. That's why what we were doing 30 years back is certainly not valid today. Today we have a lot of patients who have multicentric tuberculosis, and at the moment nearly all our spinal tuberculosis are multicentric tuberculosis. They have at least 1 asymptomatic lesion somewhere in the spine. The other thing we were taught was that, what I told you earlier, 50% of the lesions are in the thoracolumbar junction, 33% are paradiscal lesions. Now this is another very interesting thing. Unless you have a pickup rate which is so high, you will never pick up a disease early enough to make out where the disease has originated in the vertebra. The origin is often in the paradiscal region, we know that. But by the time they come into clinical notice, till they come to a doctor and we start doing imaging for them, it has spread all over the vertebral body. It's the body, anterior, posterior, all elements are affected. So very rarely do we get a case early enough to predict the origin of the lesion. The second thing is 66% have abdominal or thoracic lesions. This is from Tuli's data of 10,000 odd cases. So, I mean, statistically his numbers are huge, but the investigative modalities that they were using those days were plain X-rays. They didn't even have ultrasound to pick up abdominal lesions or the thoracic lesions. So, we do not know how this data was achieved. Today we find very few patients, even in endemic regions like Pune. We're just coming out with another paper now. Endemic lesions, spinal tuberculosis, who also have pulmonary tuberculosis, next to zero, hardly ever. So all the patients who have spinal tuberculosis, you put them to a sputum AFB test, all of them are negative. Put them on a chest X-ray, all of them are negative. So concomitant pulmonary lesions or abdominal lesions, contrary to traditional wisdom, is very, very rare. This is unpublished data, but that's our observation, even in an endemic region like Pune. The other thing is paraspinal abscess. I already told you it's not so common. One of the observations that posterior element disease is very rare. Tuberculosis is the disease of the vertebral body. The neural arch and the spinous process and the posterior elements rarely get affected. That's something we know. It's like the gospel truth. But is that really true? This is because we were basing our diagnosis on X-rays. The moment you look at MRI scans, though the disease is still predominantly vertebral body lesion, if you look at the axial sections, nearly every case of spinal tuberculosis, you will find that the disease is progressing through the pedicles into the neural arch, into the facet joint, into the spinous process, into the paraspinal muscles. It progresses. It's just a matter of time. Just give it time, it will spread through the entire vertebral body, because that's the path of least resistance through the medullary canal of the pedicle to reach the posterior element. It doesn't take much time at all. So the concept that tuberculosis affects only the vertebral body and posterior element disease is rare was because they were diagnosing based on X-ray. So that presumption no longer holds good. Let's come to making a diagnosis. The first step is the imaging studies. Vast majority of the patients with spinal tuberculosis present with back pain, in addition to all the systemic clinical features. Back pain is the predominant thing, so imaging is what you do. Clinical examination, of course, is most important. And the earlier authors who said that plain X-ray is adequate, this is completely untrue now. Plain X-ray is not adequate. It's simply not adequate. You miss out on a lot of lesions. You miss out on a lot of asymptomatic lesions. You miss out on a lot of symptomatic lesions. Today, MRI is the gold standard. So you have Shekhar Bojraj from Bombay and Raja from Coimbatore, who have published 2 extensive reports in the last 1 decade. Both of them have conclusively suggested that you need MRI scan to diagnose spinal tuberculosis. Do not depend on the traditional literature which says that plain X-ray is adequate. It is not adequate. MRI is the current gold standard. Isotope bone scan is not sensitive at all for tuberculosis. It's excellent for pyogenic infections, brucellar infections, other things, but for tuberculosis, it's a cold abscess. You will not see a hot lesion in an isotope bone scan as you would normally do. CT scan has got a very limited role. It will show you the extent of bone destruction, which I'm going to show you in a picture, but the key investigation is the needle biopsy. You cannot start antituberculous treatment without a biopsy. Again, I'll show you in a minute why. So this is a CT scan. Now the CT scan has got a great advantage. It doesn't show you the cold abscess. It probably doesn't show you the epidural abscess, but it does show you the precise extent of the bony destruction. The exact amount of bone that is damaged and how much bone you'll have to replace if you're doing a surgery, how much of area you have to fill with graft is shown here very nicely. But on the same patient, if you look at the MRI scan, it will show you the soft tissue abscess. There's an abscess anteriorly, there is an epidural abscess posteriorly, which is pressing on the spinal cord. So the soft tissue details are better seen on the MRI, the bony details are better seen on the CT scan. So both are complementary investigations for 2 different purposes. But MRI is the gold standard for diagnosing spinal tuberculosis. Just a few points of differentiation between pyogenic dyskitis and tubercular dyskitis. Both are equally common. Why do you see so many tuberculosis? Again, once we started investigating for pyogenic dyskitis, we have found there is an increasing number of pyogenic dyskitis. We just mentioned in the last 6 months we treated 12 tuberculosis. We have operated 9 pyogenics as well at the same time. So though we have operated 12 tuberculosis, at the same time there are 9 pyogenics sitting there, which we would not have diagnosed unless we had gone back and done a biopsy. So biopsy is mandatory. Pyogenic dyskitis is almost as common as tubercular. There are some simple tips and tricks which will help you diagnose them on the MRI. One of them is called the floating disc sign. So So if you look at the MR, this is a T1 and a T2 weighted image. So if you look at these images, you'll find there is a big blob of pus, the white thing, and in the center of it you can see a disc floating like this, the black one. Similarly here there's a big blob of pus, and here there's a disc floating in the center. That floating disc almost invariably happens in tuberculosis. It rarely happens in pyogenic dyskitis. I'll again tell you why in a minute. Here's another example which I showed you earlier. Here there is no floating disc, the disc has been destroyed completely. This black line was the end plate of the disc, the hyaline cartilage end plate of the disc was this black line, that has been completely destroyed. That suggests that it's a pyogenic dyskitis, not a tubercular dyskitis. Why is that? Tuberculosis is a very innocuous organism. It doesn't have any proteolytic enzymes. It is incapable of destroying any tissue around it, the tuberculous organism. It just sits there and enjoys life. It cannot destroy any surrounding tissue. Whereas pyogenic bacteria, they secrete proteolytic enzymes and they will destroy everything in the surrounding vicinity. And that's what this bug is doing here. Whereas tuberculosis, I think you know, is a delayed hypersensitivity reaction. The bacteria doesn't destroy or kill anything. It is the immune response of the body that destroys it, and that's why you get this caseation necrosis in the center, a huge bundle of lymphatic cells with epithelioid cells and all these giant cells and Langerhans giant cells and all that. Why do you get that? Because it's an immunological reaction. The destruction, the damage to the tissue happens not because of the tuberculous bacillus, but because of the body's immune response to that bacillus. So it's a completely different mechanism. Therefore, that is why in tuberculosis, it's incapable of destroying the disc. The disc is an avascular tissue. So the tuberculous bacterium cannot destroy the disc. Whereas the pyogenic bacterium will destroy the disc very early. It will secrete proteolytic enzymes and destroy the disc. So early destruction of the disc suggests that it's pyogenic, and otherwise it is tuberculosis. So this is a very recent paper which came in the Bone and Joint Surgery 2020 paper. Anil Jain is from All India Institute, and they have published this very important paper, and what it says is clinical diagnosis, no go. If you say that, you know, typically socioeconomically poor child, malnourished, he's got back pain, deformity, evo, hoo-ha, night sweats, chills and drag, we know it is tuberculosis, but it is not enough. It's simply not enough. The other thing is therapeutic trial. You know, why don't you give him 6 weeks of anti-tuberculous treatment? If he gets better, you know it is TB, and then you continue it. This is something that most of us used to do or still do. Absolutely prohibited, cannot do. Imaging, as I told you, can give us a clue whether it is pyogenic or tubercular, but it doesn't conclusively prove. We need a histological sample to say this is pyogenic bacteria. You need a blood sample, brucellar antigens, to say whether it's brucella or not. Therefore, it is mandatory to have a tissue diagnosis. Empirical therapy should never be done in tuberculosis because it gives rise to multi-drug resistant tuberculosis. I'm going to show you the statistics of Mdr tuberculosis in India, which is also absolutely shocking. I don't know whether you know, a couple of months back, I think it's 4 months back, in Sion Hospital, a young lady doctor, I think she was 26 years old, she was a postgraduate resident, she died of something called TDR tuberculosis. We started some years ago with MDR tuberculosis, then we graduated to XDR tuberculosis. Now there's something called TDR tuberculosis. It's totally resistant to all drugs available on that anti-tubercular panel. And she was being treated with paracetamol. She was 26 years old when she died because none of the drugs on the panel were sensitive. Why does this happen? And why does this happen in a premier institute like Sion Hospital? Why does it happen in a cultural center in the industrial capital of India like Mumbai? So that's what we are bringing this up to. Now this is a very important slide. This is what I'm coming to. Primary MDR occurs in about 3.5%, which means the bacteria has spontaneously developed drug resistance by mutation or evolution. It has developed drug resistance in 3.5%. But if you start treatment, that 3.5 becomes 27%. So inappropriate treatment. Just imagine a child whom you're treating clinically with 4-drug anti-tuberculosis treatment. There are 2 bacteriostatic drugs and 2 bactericidal drugs, correct? In the 4-drug, INH, rifampicin, streptomycin, ethambutol, and pyrazinamide. Those are the 4 drugs that we start with. 2 of them are cidal and 2 of them are static. Now, if the patient happens to be resistant to the 2 cidal drugs, but sensitive to the 2 static drugs, The patient will still improve because the two static drugs are sensitive, but the cidal drugs are resistant. The tuberculous bacteria doesn't die. He'll just stay there happily, enjoy the anti-tuberculous treatment, and he will come back with a vengeance. That's the problem. That is why this is happening. So treated patients have a much higher prevalence of Mdr tuberculosis in India, and of course the capital of Mdr tuberculosis is UP, but you also have in Haryana, Maharashtra is second. You have a very large number of Mdr tuberculosis in India. Whereas though primary tuberculosis is much higher in this coastal belt, on the eastern coastal belt, Mdr tuberculosis is very low on the eastern coastal belt. Though primary tuberculosis is high in Kashmir and Punjab, Mdr tuberculosis is very low there because most of it is because of compliance with treatment standards. The other thing is Mdr, I think you know the definition of Mdr, it has to be resistant to INH and rifampicin, two drugs. But if you look at single drug resistance, there's a much higher innate resistance, about 25%. 1/4 of all the tuberculous bacteria are resistant at least to one drug. One of the 4 standard drugs that you give are resistant, 25%. But the moment you treat a patient inappropriately, that becomes 60%. If you have not hit the patient correctly during the first time and destroyed the bacteria completely, there is a big risk. 60% chance he is going to come back with a vengeance with a multi-drug resistant tuberculosis. And then out of these 4 drugs, many of them will be resistant. So that's the problem. So this is a very recent paper. This is 2020 paper which shows us the statistics of Mdr tuberculosis in India, and this itself is very alarming or scary, the difference between the two. The other thing is diagnostic tests. Okay, many of us are fond of using the Mantoux test. Mantoux test is completely useless as a diagnostic test. It does not diagnose tuberculosis at all. It tells you whether you have at some point in your lifetime and career developed resistance to tuberculosis, immunity against tuberculosis. That's all it tells. It should never be used as a diagnostic test for tuberculosis. The other thing is Igm and Igg. Some of us still do Igm and Igg. They are very poor in sensitivity and specificity. Both of them have sensitivity around 60 to 70%. Specificity is even less, 30 to 40% specificity is what they have. So doing a blood test of Igm and Igg is not at all recommended for any kind, whether it's pulmonary tuberculosis, spinal tuberculosis, extrapulmonary is not recommended at all. Currently the gold standard is either to do a quantiferon gold, which is a gamma interferon assay, or to do one of the cartridge based nucleic acid amplification tests. All of them are available here and they are not that expensive, either Gene Expert or CBNAT. Of course, one of the best tests, if you can do it, is the line probe assay. It is still available here. There are some newer tests coming up, just like the polymerase chain reaction. You have another enzyme which is being tested, which is called the ligase chain reaction. In fact, WHO recommends the ligase chain reaction much more than the PCR. It's supposed to be, even PCR has got a 98% sensitivity and something like 91, 92% specificity. The ligase chain has got a much higher sensitivity and specificity. So if you can do an LCR, that's even better. I'm not aware of the availability. From your point of view, this is perhaps the single most important slide in this whole presentation. The top of the pyramid is mycobacterial culture. This is the current state of evidence. But you can't get a mycobacterial culture in every case. Many of them they are paucibacterial diseases. Pulmonary tuberculosis is a polybacterial disease. You have a lot of bacteria. But in the spine, in the peritoneum, in the lymph node, they are all paucibacterial diseases where you have only very few organisms present there. But the immunological response is great. You will not always get a culture. The next best is molecular methods. But ZN stain and histopathological evaluation, identification of a tubercle, identification of the Langerhans giant cells, epithelioid cells, the classic tuberculoma is considered, mandatory. So these 3 form the mainstay of your diagnosis. This is completely unacceptable. Radiological imaging alone, clinical suspicion not acceptable alone, therapeutic response absolutely the worst thing. Absolutely the worst thing, which is something that we very often do, not acceptable at all. Hit the patient with ATT, खांसी जुकाम है, उसको ATT दे दो, 6 हफ्ता दे दो, क्या होगा? And he'll invariably get better. Even if it's a bacterial disease, they'll get better because you're giving them rifampicin or streptomycin. The moment you give rifampicin, even bacterial infections will get better. So that's absolutely not the way to treat patients. So the latest update of RNTCP is in February 2020. I think The treatment for tuberculosis, whether it's tuberculosis, spinal tuberculosis, I'm coming back to spinal tuberculosis, the main topic of today. The treatment is still chemotherapy. The first line treatment is still chemotherapy. Surgery is an adjuvant to the chemotherapy. How do we cure tuberculosis? Not by surgery. We cure tuberculosis by the chemotherapy, and the first line drugs are the same, streptomycin, PAS, we don't use PAS anymore. We use ethambutol or ethionamide and pyrazinamide are the drugs that are used. Okay. We have just recently completed a systematic review which is up for publishing now. We basically followed, I think you know all this, the PRISMA guidelines for systematic reviews. We looked at 5,673 articles of adult spinal tuberculosis. We segregated the pediatric tuberculosis and looked at the adult spinal tuberculosis. We shortlisted 298 papers, international papers of tuberculosis from different parts of the world. Looked at, some of them were using anterior approaches, some of them were using posterior, some of them were using combined approaches. We were using this to compare it with our own evolution in the last 40 years that we've been operating on the spine, just try to evolve the statistics of what was happening. So from 1956 to 1982 was called the biological era, where we were just starting the chemotherapy. So supplementing the chemotherapy, you wanted to reduce the disease burden by removing all the disease tissue. Which if it was spine, you remove it. If it was lymph node, you remove it and then reconstruct it. Those days, they were using only bone graft. Autologous bone graft was the only thing that was being used. Then came the mechanical era from the 80s to 2000. In addition to the debridement, we were stabilizing with various kind of mechanical instruments and also to achieve earlier fusion so that we could mobilize the patient early. In the earlier phase of debridement, they had to be in a plaster jacket or in a plaster shell. So they were just laid in bed after the surgery for 3 months, 6 months, till the chemotherapy worked and the patient got better. And lately in the last 20 years, last 2 decades is what we have described as the technological era. We have been doing minimally invasive techniques, endoscopic debridement techniques, local drug delivery systems, put a indwelling catheter into the spine and deliver chemotherapeutic agents there. Bioactive materials, which is some of the examples that, some of the experiments that we have been doing for the last 10, 15 years. I'll give you some examples. So obviously we need to have evidence-based data as we progress through these various stages. The indications for surgery have always remained the same. Obviously you need a tissue diagnosis. If you cannot get it through a CT guided biopsy, you need to have a surgery for open biopsy. Neurological deficit is the second major issue. Progressive deformity is the third issue. Instability causing pain, advanced vertebral destruction, etc. Sometimes for large cold abscess, today we know that however large the cold abscess is, you can completely remove it without surgery. With chemotherapy alone, you can completely remove the cold abscess. Surgery is not necessarily indicated for that. But the disease load, the disease burden on the body will substantially reduce if you remove the cold abscess. That does happen. And failure of non-operative management. So the purpose of the surgery is to correct neurology. You decompress the spinal cord to stabilize and relieve pain and mobilize the patient immediately. The moment you put instrumentation in, the patient doesn't have to bed rest anymore. You can get him up and out of bed. You need to remove the diseased tissue, replace it with normal healthy bone, correct the deformity, and to obtain tissue samples. I'll go through our own history from several years. This is starting in 1988 when we were doing the so-called Hong Kong procedure. And this is an example of, those days we had only X-rays, there'll be no MRIs on this earlier part of the series. So that's a tuberculosis disease, and in this case it was done debrided, and he had a iliac crest graft. Now these iliac crest grafts, these patients are kept in bed for about 3 months to 6 months till the pain is completely reduced, the wound is healed, the bone is united, and then they can mobilize. In the early 90s, we started instrumenting the spine. This is a case where the tuberculous tissue has been removed. You can see a block of graft placed in there, and it has been simultaneously. These are all done transthoracic. You have to do a thoracotomy and go into the thorax and then do this instrumentation. By 98, we started graduating into other forms of instrumentation. Instead of putting an autologous graft, instead of taking out a big chunk of iliac crest bone or taking out a fibula or rib, we were putting these cages here. We were putting these cages here. It's a mesh cage which is structurally strong enough to support the spine, and we can mobilize these patients immediately. This is from 1998. Then came an era where we are doing combined anterior and posterior procedures. This, you can see a bone graft sitting here. This is a tricortical iliac bone graft. So debride, remove the diseased tissue, put a bone graft, at the same sitting go from the back and instrument the spine, so the patient doesn't have to be in bed, you can mobilize the patient immediately, you can achieve neural decompression. This is also a combined front and back surgery. So this was all done during the late 90s, early 2000s. We experimented with several other procedures, spine shortening procedures. Instead of restoring the height of the diseased vertebra, we were removing the diseased vertebra and shortening the spine, and did some procedures like this as well. Then came a period of non-structural grafting. Instead of putting blocks of bone, either fibula or iliacrus bone, we just started mincing bone and putting it into the spine. From 96 onwards, we started what is called the local drug delivery system. There are different systems available for local drug delivery. Streptomycin is the drug of choice because it's water soluble. There are Chinese authors who use INH also, because INH is also water soluble. You can put INH into a drug delivery system, either an insulin delivery pump or a continuous inflow catheter, and you can deliver the drug directly into the diseased tissue. What we were using instead was ceramics. These are all biodegradable ceramics. In the earlier experiments, we started with hydroxyapatite, which is the normal calcium phosphate of bone. So hydroxyapatite is the best to be put in bone. Then we used hydroxyapatite with bioactive glass. Today we are using nanoporous hydroxyapatite with bioactive glass. So it looks something like this. They are porous ceramic granules, and you impregnate them with streptomycin in the OT itself, and you replace the bone with that. So here's an example of one of the earlier cases that was done. There's a completely flattened out vertebra here. That has been restored to its normal height, and if you look very carefully, you can see some whitish granules here, some whitish dots there. That's the ceramic, and this is after healing. 1 year after healing, the vertebra is maintaining its height and the ceramic is there. It is still integrated. So here's another example of ceramics used for. So these are drug-eluting ceramics. One of the problems with spinal tuberculosis is that the vascular supply is less in the vertebra compared to the lung, which is very vascular. So therefore the drug does not reach there in adequate quantities. This is one of the hypotheses that we use for this local drug delivery system. And you can find that we still use this both in our pyogenic dyskitis as well as all kinds of spondylodiscitis, whether it's brucellar, pyogenic, tuberculosis, they all have a local drug delivery in addition to the systemic drug delivery. For pyogenic, we usually use vancomycin. For tuberculosis, it's streptomycin. For brucellar, it's tetracycline is typically what we use, or streptomycin, one of the two can be used. So what are the challenges that we have in future? One of the biggest issues is duration of treatment. Almost all spine surgeons will tell you that the 6 months of RNTCP, the RNTCP guideline is constant. The WHO guideline is constant. Pulmonary tuberculosis and extrapulmonary tuberculosis have exactly the same duration of treatment, which is 6 months. 2 months of intensive treatment. Once the sputum negativity is reversed, as the sputum positivity is reversed, it becomes sputum negative. You can continue for another 4 months with your. That is the RNTCP guideline. That is the WHO guideline also. But because the vascular supply to the spine is less, the organisms are fewer. Most of the surgeons feel that osteoarticular tuberculosis, whether it's spinal or other peripheral joints which are affected by tuberculosis, need a longer period of treatment. There is no arbitrary, there's no end point. Some people have said 9 months, some people have said 12 months, some people have said even 2 years. The older generation of Tuli and Shanmugasundaram and all the stalwarts of tuberculosis in India would tell us 24 months is still required for anti-tuberculosis treatment. That has not been true in our experience. We still use the RNTCP guideline. We gave it only for 6 months, and our results have been as good or as bad as everybody else's. There's no difference in giving that. So the duration of treatment is 6, maximum 9 months. If your serial imaging studies, if your serial serological studies, if your serial biochemical studies have not improved adequately, you might continue it for 9 months. We hardly ever continue it beyond 9 months. So 6 months is adequate in my opinion. You need not continue it. For pulmonary tuberculosis, the advantage is you have an endpoint for treatment, that is sputum negativity. So your active phase of treatment continues only till you get sputum negativity. But in spinal tuberculosis, what is the endpoint? Is it imaging? Is it some kind of serology, ESR, CRP or something? Or is it some other endpoint, clinical endpoint? Patient feels better and happy. We don't know. There's no endpoint. You can't do a rebiopsy. So there's no rehistological sampling done. So we do not know the endpoint, so we have to do based on very empirical endpoint. At this moment, there are no endpoints in spinal tuberculosis, so we have to follow international guidelines, and the international guidelines are 6 months. You may choose to extend it up to 9 months. There's absolutely no indication for going beyond 9 months. So ladies and gentlemen, the key messages of what I've been trying to tell you in the last 30-35 minutes is that one is read about the epidemiology. The epidemiology of tuberculosis is so important because tuberculosis everywhere in India is not the same. While I was preparing this lecture, I read another paper yesterday. The highest incidence, the HIV incidence, co-infection HIV and tuberculosis in India is approximately 1%. It's not very, 3.5% in some literature, 1%. But the highest is, can you imagine where? Nagaland, Manipur, Mizoram has got the highest incidence of HIV co-infection with tuberculosis, something in the region of 28-30%. Karnataka is the next. Interestingly, Maharashtra does not have a very high HIV tuberculosis co-infection. Tamil Nadu, Karnataka has got much higher HIV co-infection. But the drug-resistant tuberculosis, Maharashtra is the capital. UP and Maharashtra are the capitals of drug-resistant tuberculosis in India. So we must be aware of all these epidemiological variations that can happen. Similarly, in a state like Kerala, you must be aware that children do not get spine TB in Kerala, because if you diagnose a child with spine TB, you're clearly wrong. That's why the epidemiological variations of the disease within our country itself are important to understand. The second message is, don't start empirical ATT for any case, spinal TB, extrapulmonary TB, or whatever TB. The diagnosis is, the best diagnosis is histology. The next best diagnosis is molecular markers. So molecular markers have got 98% sensitivity and 91% specificity, so they are the best tests that we have today. As far as spinal tuberculosis is concerned, the indications and the surgical strategy are very customized depending on what the patient has got. If he has got predominantly deformity, there is one type of surgery. If he has got predominantly neurological compression with paralysis, he's got another type of surgery. If you want to reduce the disease load by removing the psoas abscess or the extravertebral abscess, that's got a different type of surgery. That is customized to the patient's needs. So that's my message. If you have any questions, I'll be happy to answer.